Management of glioblastoma multiforme in a patient treated with ketogenic metabolic therapy and modified standard of care. A 24-month follow-up. Few advances have been made in overall survival for glioblastoma multiforme, GBM, in more than 40 years. Here, we report the case of a 38-year-old man who presented with chronic headache, nausea, and vomiting accompanied by left partial motor seizures and upper left limb weakness. Enhanced brain magnetic resonance imaging revealed a solid cystic lesion in the right partial space, suggesting GBM. Serum testing revealed vitamin D deficiency and elevated levels of insulin and triglycerides. Prior to subtotal tumor resection and standard of care, SOC, the patient conducted a 72-hour water-only fast. Following the fast, the patient initiated a vitamin-mineral supplemented ketogenic diet, KD, for 21 days that delivered 900 calories per day. In addition to radiotherapy, temozolomide chemotherapy, and the ketogenic diet, increased to 1,500 calories per day at day 22. The patient received Metformin, 1,000 mg per day, Methylfolate, 1,000 mg per day, Chloroquine phosphate, 150 mg per day, Epigallocatechin gallate, 400 mg per day, and hyperbaric oxygen therapy, HBOT, 60 minutes per session, 5 sessions per week at 2.5 ADA. The patient also received levetiracetam, 1,500 mg per day. No steroid medication was given at any time. Post-surgical histology confirmed the diagnosis of GBM. Reduced invasion of tumor cells and thick-walled hyalinized blood vessels were also seen, suggesting a therapeutic benefit of pre-surgical metabolic therapy. After 9 months treatment with the modified standard of care and complementary ketogenic metabolic therapy, KMT, the patient's body weight was reduced by about 19%. Seizures and left limb weakness resolved. Biomarkers showed reduced blood glucose and elevated levels of urinary ketones with evidence of reduced metabolic activity, choline to N-acetyl-aspartate ratio, and normalized levels of insulin, triglycerides, and vitamin D. This is the first report of confirmed GBM treated with a modified standard of care together with ketogenic metabolic therapy and HBOT, and other targeted metabolic therapies. As rapid regression of GBM is rare following subtotal resection and standard of care alone, it is possible that the response observed in this case resulted in part from the modified standard of care and other novel treatments. Additional studies are needed to validate the efficacy of ketogenic metabolic therapy administered with alternative approaches that selectively increase oxidative stress in tumor cells while restricting their access to glucose and glutamine. The patient remains in excellent health, Karnofsky score 100%, with continued evidence of significant tumor regression. Background: Glioblastoma multiforme, GBM, is the most common and malignant of the primary adult brain cancers. Although survival is better in younger adults, younger than 50 years, than in older adults, less than 20% of younger adults generally survive beyond 24 months. Accumulating evidence from cell culture studies and preclinical models indicate that glucose and glutamine are the primary fuels that drive the rapid growth of most tumors, including GBM. Glucose drives tumor growth through aerobic fermentation, Warburg effect, while glutamine drives tumor growth through glutaminolysis. The fermentation waste products of these molecules, i.e. lactic acid and succinic acid respectively, acidify the tumor microenvironment, thus contributing further to tumor progression. Glucose and glutamine metabolism is also responsible for the high antioxidant capacity of the tumor cells, thus making them resistant to chemo and radiotherapies. The reliance on glucose and glutamine for tumor cell malignancy comes largely from the documented defects in the number, structure and function of mitochondria and mitochondrial-associated membranes. These abnormalities cause the neoplastic GBM cells to rely more heavily on substrate-level phosphorylation than on oxidative phosphorylation for energy. Hence, the effective management of GBM will require restricted availability of glucose and glutamine. The current standard of care, SOC, for GBM involves surgical resection and radiotherapy with concomitant and adjuvant temozolomide. High-dose steroid, dexamethasone, is often prescribed along with the standard of care for GBM to reduce vasogenic edema. It is now recognized that surgical resection and radiotherapy produce significant necrosis and hypoxia in the tumor microenvironment. These disturbances disrupt the tightly regulated glutamine-glutamate cycle in the neural parenchyma, thus increasing the levels of glutamine and also glutamate, an excitotoxic amino acid that enhances GBM invasion. Although temozolomide increases progression-free survival, it has only marginal effect on overall survival and actually increases the number of GBM driver mutations. Moreover, dexamethasone not only increases blood glucose levels but also increases glutamine levels through its induction of glutamine synthetase activity. The anti-angiogenic drug bevacizumab, which exacerbates radiation-induced necrosis and selects for the most invasive tumor cells, is also widely prescribed to GBM patients. Viewed collectively, these observations may help explain why overall survival remains poor for most GBM patients. Ketogenic metabolic therapy, KMT, is emerging as a viable complementary or alternative therapeutic strategy for the management of malignant gliomas. Calorie restriction and low-carbohydrate, high-fat ketogenic diets reduce the glucose needed to drive the Warburg effect, while also elevating ketone bodies that cannot be effectively metabolized for energy in tumor cells, due to defects in mitochondrial structure and function. Calorie restriction and restricted ketogenic diets are anti-angiogenic, anti-inflammatory, anti-invasive, and also kill tumor cells through a pro-apoptotic mechanism. Evidence also shows that therapeutic ketosis can act synergistically with several drugs and procedures to enhance cancer management, improving both progression-free and overall survival. For example, hyperbaric oxygen therapy, HBOT, increases oxidative stress on tumor cells, especially when used alongside therapies that reduce blood glucose and raise blood ketones. Chloroquine inhibition of lysosomal pH can prevent invasive and metastatic tumor cells from obtaining glucose and glutamine through phagocytosis or autophagy. The glutamine dehydrogenase inhibitor, Epigallocatechin gallate, EGCG, is also proposed to target glutamine metabolism. Hence, ketogenic metabolic therapy targets the multiple drivers of rapid glioma growth while enhancing metabolic efficiency in normal brain cells. Case report. A 38-year-old male presented on February 2016 with chronic headache, nausea and vomiting with left partial motor seizures and weakness in the upper left limb. The symptoms persisted for about 3 weeks before further diagnostic and radiological evaluation. Neurological examination revealed grade 4 left upper limb weakness with mild left facial deviation. There was no history of chronic disorders or malignancy. The patient's blood pressure was within normal limits. Laboratory investigation revealed unremarkable blood chemistry, with liver and renal functions within normal limits. Fasting blood glucose was normal, but fasting insulin level was elevated, suggesting some degree of insulin resistance. Enhanced magnetic resonance imaging, MRI, of the brain showed a solid cystic intra-axial occupying lesion in the right partial space. MR tractography revealed displaced motor and sensory fibers. The preliminary diagnosis was GBM. The patient's caloric intake at diagnosis was approximately 2,200 to 2,500 calories per day, estimated from a 3-day food record and a 24-hour diet recall. The patient underwent a 72-hour water-only fast immediately after preliminary diagnosis and before any medical or surgical treatment. Consumption of a calorie-restricted ketogenic diet, KDR, for 23 days followed the fast. Figure 1a. Timeline of clinical course with dates of dietary treatments. Magnetic resonance imaging, MRI, magnetic resonance spectroscopy, MRS, and hyperbaric oxygen therapy, HBOT. Measurements of glucose, ketones and insulin were taken at the laboratory in the morning. Urine ketones were scored as plus, and triple plus, corresponding to median capillary blood ketone levels of 0.5 millimolar, 0.7 millimolar, and 3 millimolar respectively. A ketogenic diet, 4:1 ratio, fat calories to protein plus carbohydrate calories, was administered to the patient in restricted amounts for 21 days after the fast and before surgical tumor resection. This restricted ketogenic diet delivered an average of 900 calories per day in total, which included the following. 1. 71 grams equals 639 calories fat, 33% as olive or flaxseed oils, 33% as medium-chain triglycerides, 33% as organic butter. 2. 50 grams equals 200 calories protein, poultry, fish, eggs, with no more than 15% dairy. 3. Carbohydrate 15 grams equals 60 calories, mainly from green leafy vegetables after subtracting the amount of carbohydrates in protein sources. And 4. 20 grams equals 0.1 calories from fiber. The restricted ketogenic diet was supplemented with B-complex vitamins, minerals, calcium, magnesium and omega-3 fatty acids to maintain nutrient adequacy and normal blood chemistry. Vitamin D3 was prescribed, 5,000 IU per day, to correct the patient's vitamin D deficiency. Other additions included Metformin, 1,000 mg per day, and Methylfolate, 1,000 mg per day. The patient's glucose ketone index, GKI, a calculation that tracks the ratio of blood glucose to ketones as a single value, remained in the predicted therapeutic range. Figure 1b. No steroids, dexamethasone, phenytoin or sugar-based osmotic diuretics, mannitol, were given to the patient. After 21 days following initiation of the restricted ketogenic diet, the patient underwent an awake craniotomy with subtotal tumor resection. The suspected diagnosis of GBM was confirmed by histopathology of tumor tissue. Regressive and regenerative changes not typical of untreated GBM were noted, possibly reflecting a favorable response to preoperative ketogenic therapy. The patient's postoperative recovery was excellent with no signs of previous left weakness or seizures. The patient's blood glucose level was 64 mg per deciliter and his urine ketone level was triple plus, producing an approximate GKI of 1.3. The patient was discharged to home 2 days after surgery. The restricted ketogenic diet was continued together with 14 hours daily fasting between dinner and breakfast. Together with the previously mentioned medication and supplements, the patient also received chloroquine phosphate, 150 mg per kilogram, and EGCG, 400 mg per day. 2 weeks postoperative, the patient began receiving HBOT, 2.5 ATA for 60 minutes, 5 times per week. Enhanced brain MRI and magnetic resonance spectroscopy, MRS, evaluated 3 months postoperative and before radiation or chemotherapy revealed a stationary course of disease regarding tumor size that persisted to 12 months. The patient was neurologically intact and free of clinical seizure activity using only levetiracetam, 1,500 mg per day, and the ketogenic diet. Fasting glucose was 60 to 70 mg per deciliter with plus to triple plus urine ketone levels and producing an approximate GKI value of 1.8. Circulating insulin was low, approximately 4 IU, compared with the initial assessment of 13 IU. The patient's body weight was 67.7 kilograms with a BMI of 23.7. Radiotherapy with oral temozolomide, 75 mg per square meter orally once a day for 42 days, was initiated 18 hours after water-only fasting. No food was consumed for up to 8 hours following radiotherapy and temozolomide. The patient also received 20 sessions of HBOT, 2.5 ATA, 5 days per week, for 60 minutes per session. The patient continued with 30 sessions of brain radiation and completed his temozolomide loading without significant side effects or noticeable neurological deficits. After 9 months of therapy, the patient's weight was reduced to 56.9 kilograms, BMI 19.9. Despite the reduced BMI, the patient experienced no distress or discomfort. At this point, the patient transitioned to consuming an unrestricted ketogenic diet with total calories around 1,500 kilocalories per day. Fasting blood glucose was around 70 to 75 mg per deciliter and urine ketone levels were plus, producing an approximate GKI of 5. Figure 1b. Figure 1b. The glucose ketone index, GKI, indicates the ratio of circulating glucose to urinary ketones at all 8 clinical assessments during the 15 months period from February 2016 to April 2017. After 20 months of metabolic therapy and completion of radio and chemotherapy, the patient's weight was 66.2 kilograms, BMI 23.2. Enhanced brain MRI and MRS revealed decrease in tumor size of about 1.5 centimeters in each diameter, with minimal perfusion and low metabolic activity. Fasting insulin, glucose and urine ketones were 2.1 IU, 65 milligrams per deciliter, and plus to plus plus respectively, producing an approximate GKI of 5.0. A reduction in tumor size was correlated with a correction of the midline shift after 20 months of treatment, figure 4b. The patient remains in good health with no noticeable clinical or neurological deficits. Karnofsky score 100%. Figure 4b. Comparison between tumor size and midline shift, red line, over 20 months. Discussion. In this case report, we describe a favorable therapeutic response to ketogenic metabolic therapy and other treatments targeting metabolism in a 38-year-old man with GBM and metabolic imbalances. Ketogenic metabolic therapy is a nutritional anti-neoplastic intervention involving ketogenic or low glycemic diets for managing malignant gliomas. The standard of care for GBM was modified in this patient to initiate ketogenic metabolic therapy prior to surgical resection, to eliminate steroid medication, and to include HBOT as part of the therapy. Specific drugs and dietary supplements were also used in the therapy. Previous studies showed that a ketogenic diet is well tolerated for most GBM patients, but therapeutic efficacy can vary among patients perhaps due to differences in the degree of calorie restriction. Few of the adult GBM patients treated with ketogenic diets in these studies were able to reach or maintain the GKI predicted to have the greatest therapeutic benefit for patients, near 1.0. However, an excellent therapeutic response to the ketogenic diet was seen in 2 children with high-grade gliomas. Previous studies showed that GBM survival and tumor growth was correlated with blood glucose levels, i.e. the higher the blood glucose was, the shorter was the survival, and the faster was the tumor growth. As the dexamethasone steroid is often prescribed together with the standard of care for GBM, the elimination of this steroid treatment could have contributed in part to the reduced glucose levels and favorable outcome observed in our patient. Evidence indicates that glioma cells cannot effectively use ketone bodies for energy due to defects in the number, structure, and function of their mitochondria. The accuracy of the GKI as a predictor for therapeutic efficacy, however, is better when ketone bodies are measured from the blood than when measured from the urine. Nevertheless, the low GKI values observed in our patient following ketogenic metabolic therapy was in the direction of predicted therapeutic success for reducing lactic acid fermentation. A reduction of glucose-driven lactic acid fermentation would not only increase tumor cell apoptosis, but would also reduce inflammation and edema in the tumor microenvironment, thus reducing tumor cell angiogenesis and invasion. Although ketogenic metabolic therapy is effective in targeting the Warburg effect in GBM cells, it would be less effective in targeting glutamine, the other major fuel that drives GBM growth. Besides serving as a metabolic fuel for GBM, glutamine is also an essential metabolite for normal immune cells. Macrophages in particular are needed to repair the microenvironment and to remove dead tumor cells following metabolic therapy. Therefore, therapies that inhibit glutamine availability and utilization must be strategically employed to avoid inadvertent impairment of immune cell functions. It can be difficult to restrict glutamine without also impairing important functions of normal immune cells. Consequently, we use the non-toxic green tea extract EGCG and chloroquine in an attempt to limit glutamine availability to the tumor cells. EGCG is thought to target the glutamate dehydrogenase activity that facilitates glutamine metabolism in GBM cells. Chloroquine, on the other hand, will inhibit lysosomal digestion, thus restricting fermentable amino acids and carbohydrates from phagocytosed materials in the tumor microenvironment. We also treated the patient with HBOT to increase oxidative stress in the tumor cells. We originally described how somatic mutations could make tumor cells more vulnerable to physiological stress than normal cells based on the evolutionary concepts of POTS. As glucose and glutamine fermentation protect tumor cells from oxidative stress, reduced availability of these metabolites under ketosis could enhance the therapeutic action of HBOT as we recently described. We suggest that the targeting of glucose and glutamine in a press-pulse therapeutic strategy together with a modified standard of care could have contributed to the favorable outcome in this GBM patient, despite evidence of postoperative residual tumor. Concluding remarks. Glioblastoma multiforme remains among the most aggressive and difficult to manage primary tumors of the central nervous system. Emerging evidence indicates that cancer is primarily a mitochondrial metabolic disease where tumor cells become dependent on fermentation for growth. Glucose and glutamine are the prime fermentable fuels that drive GBM cell growth and invasion. A press-pulse therapeutic strategy was implemented to target glucose and glutamine availability in a 38-year-old GBM patient using a modified standard of care and ketogenic metabolic therapy. As less than 20% of younger adults generally survive beyond 24 months with GBM, it is possible that the response observed in this case resulted in part from the ketogenic metabolic therapy and the modified standard of care. The patient is now 40 years old and remains in excellent health with no noticeable neurological issues after 24 months of treatment.